said, well,
there's a question of
telemedicine is,
I don't know. Also licensing. So in other words, if say I'm not licensed in the person, and I'm not licensed in Pennsylvania, am I allowed to give that patient a study drug?
and you're talking about basically having these satellite, almost like it supports them. How are we going to do it locally, though?
Well, let's say it's IVIG.
Yeah.
Okay.
So in other words, you would contract with an organization that has multiple sites.
That can deliver IVIG.
Yeah, I guess I'm thinking about the more weird agents and how that would be difficult. But maybe you're talking about more standard type things that can be managed in a. Well, okay. Well, that's different. Well, that's different. Well, that's fine.
Separate ambulatory infusion center setting.
That could be doable.
Right?
That could be doable.
That would be a very novel way to get rare patients into the study.
Yes, it might be be a novel way to get rare patients, and I just wonder what kind of study you could really do.
Well, so
and that's it. I'm just worried. I'm just.
So outcomes becoming a lot of questions.
Yeah.
But
monitoring, safety, outcomes,
from a pure
logistics standpoint.
From a logistics legal standpoint. I think telemedicine has the capability to do this.
Telemedicine has. I mean, you do telemedicine.
Some.
Yeah. Well, we're Rohit, I've mentioned his name a couple times. He's actually doing some telemedicine stuff, and I opted out because of time issues.
Yeah.
No, I think that's a powerful way, powerful for a lot of people.
It's a derm.
Derm is more powerful. Yeah. Derm is powerful. I know dermatologists have been doing it longer.
Stroke is big. A lot of it is you can watch a nurse examine.
The thing is that I know
whether it's real or fake. Yeah. You can actually do it. It works really well. The Mayo Clinic's been doing it. They actually designed a stroke robot. It literally is a portable video two-way system.
So it's to come here.
Really?
It's about 4 hours.
It's pretty
How long have they been doing it?
A couple years now.
Okay, Danny is here. I was going to yell at him for not being here.
So you have to change somewhere.
All right,
Todd, that's.
I'm playing around with this idea.
Who are you talking to? I mean, don't give anything away.
No. It's a neurologic study. IVIG.
For multiple indications?
Just for one. So it's called multiple commodities.
Just you don't have the time difference.
The only way
Oh, no.
it's not patients. So what happens is you get patients that are already on therapy. And basically the studies consist of withdrawing therapy, letting the patient get worse, giving
So actually to UK,
and you could,
it's only 4 hours.
do you have a trial in mind, or is it like an IVIG or something?
It's 5
So
to
the
here.
question would be, could you get naive patients? Price on one naive patient a year.
Yeah. That's why you're saying.
Right. So the
It'd be
point
great
is,
to get
I'd have to get
neurologists.
Yeah, I'd have to get 100, 200 neurologists on IR.
Yeah, Berlin is different. UK is 1 hour different from
Or
European.
let 200 neurologists know that if you have a naive patient, and they're all going to want to treat with IVIG. That's the standard treatment.
I see.
So you just say, look, we're going to treat
We're
them for 2 months. And then
But
you
these
get
are,
1 hour
you say
is
these are
okay, but
like
6 hours.
Yeah, because you got to add some meat on that.
And I'm,
If I could have your attention, we're going to get underway.
my brain is stubborn.
I'd like to start this session. We're going to try staying on time. This is being televised over the internet. Some of the physicians on the panel have planes to catch. So I want to, first off, let everyone here know that the Medical Advisory Board, and you see 17 of our 20 members up here right now, they serve on a volunteer basis. Everyone understands they're not contracted with TMA. They don't receive anything from us other than right now their airfare to come to the meeting, and we provided them with a dinner last night, and that's the entire compensation they receive from TMA over the 365 days each year. So, go ahead. I suspect everybody's had a chance to meet most of them by now. They're a very dedicated group of individuals. As you can see, we got a diversity of ages, gender, ethnicity up here, You know, they are absolutely committed to finding better treatments and ultimately a cure for this disease. And I really can't imagine having a better group of physicians who work together collaboratively and are committed to the same cause. So what I want to do, I just want to explain to you that this is an opportunity for each of them to introduce themselves, explain how they became interested in myositis, maybe talk a little bit about their current research or research that is going to be getting underway, and then it's going to be questions and answers with you. So each of their remarks should really be limited to just 2 or 3 minutes. 1 or 2 of them have a little bit more to say about some research, and they're welcome to go a little beyond that. Dr. Bob Wortman, I think most of you know him by now. He's right here. Was chair of the Medical Advisory Board, and last year he became, or the beginning of this year, he became a member of our board of directors. I'm going to let Bob MC the panel. He'll have some follow-up questions where appropriate, but mainly it's an opportunity for all you to have a chance to ask your questions. We're going to have this conclude right at 12 o'clock. So let me turn it over to Bob.
Thank you. And I guess everybody up here at the podium has heard the challenge, and so why don't we start with Dr. Mandel.
Well, it's a pleasure to serve this community, and many of you I've personally met and have visited our center. My interest in IBM is really a passion. I'd love to know what causes it, as most of my colleagues would up here, and there's been a great deal of work done on this, and we'd love to be able to find the answer. My current position is I'm the head of gene therapy at Nationwide Children's Hospital and Ohio State University, and I have joint appointments in neurology and pediatrics. I guess there's a great deal of interest in what's going on in our clinical gene therapy trial. I'll be glad to open up this to questions, but basically, just to give you a brief overview, we have had the privilege of treating the first 3 patients with inclusion body myositis, and the main thing is, as far as our studies go and the FDA goes, is we have had no adverse effects. So things are going well in that, from that perspective. Thank you. We always learn things from gene therapy trials, and we know that the one thing that we have changed in the protocol is that we started out planning to use steroids if there was an immune response. The gene therapy field has evolved to the next level, and that is now we put all patients on steroids at the time of the gene transfer. And that is a dose that probably many of you are familiar with, about 60 milligrams of prednisone, and we maintain that dose for about 6 to 8 weeks while we're monitoring an immune response. When you get, remember that the gene is delivered in a virus. The virus has none of its own genes. They're all taken out, and we put the follistatin gene in its place. But still, there's the capsid, or what we call, that's what we call it scientifically, or you can think of it as a capsule that encloses the gene and is the delivery vehicle for the gene. Once the gene gets into the muscle and we inject it at 12 sites into the quadriceps muscle, and after about 6 to 8 weeks, corresponding to when we decrease the prednisone dose, the viral capsid is degraded by the body and leaves the gene in place to do its work. So I think I'll throw it open to questions at that point and try to see if anyone has any particular things that I can answer for them at this point. Yes.
Hold on. Wait.
The way gene therapy studies are done, this was a question about recruitment. The way gene therapy studies are done by FDA standards is we do dose escalation studies. So we go from low dose, then to mid dose, then to high dose, and after each cohort, after each of those three, there are 3 patients in each cohort, we present the data to the FDA, show that there's no safety problems, and if there isn't, and we also have an oversight committee that we have to report to, and if there are no problems, then we can go on to recruit to the next cohort. We've just injected our 4th patient, and we follow patients from day 1 to day 6 months, and at 6 months we do a muscle biopsy to look at the effects of the gene transfer. So things are going well, and we're recruiting patients. Many of you have been to Children's Hospital. We have established what your baseline values are, and many of you have been contacted about being part of another cohort as things move forward in a safe manner.
Let me ask Dr. Sahenk to introduce herself since she's part of the study. And on the questions, if you'll put your hand up so we can see where you are, we need to give you the microphone before you ask your question so that people over the internet can hear the question as well. But let's let Dr. Sahenk introduce herself.
Thank you. I'm also very happy to be here. I'm the director of the Neuromuscular Laboratories, diagnostic laboratory, and my laboratory also provides to our entire gene therapy group for research purposes. I work on the polystatic gene therapy program with Dr. Mendel, and my lab has been analyzing the biopsies before and after treatment to assess the effects of the gene therapy on the muscle tissue. The diagnostic laboratory also provides service to entire Central Ohio, 27 local hospitals, as well as the Ohio State University. So that's my role in the IBM study currently.
When will you do the second biopsy? Was it 6 months or is it later than 6 months? You do a baseline and then when will you read another biopsy to see if there's been any
We
effect?
do the baseline biopsy before the treatment, and 6 months after treatment we do the second biopsy and do the analysis.
You said that there were no adverse effects. Have you been able to detect positive effects? And could you be specific?
I'll be very specific about what we've seen, and that is we call a biologic effect. So this means that when we put the virus and the gene into the muscle, we were able to monitor follistatin levels in the blood, and the patients that we injected developed increased levels of follistatin in the blood. That means the gene is working, and that's a very important part of what we have identified. The other part of that is that without without seeing a biologic effect in the muscle, you can't assess safety as well. And when you're presenting this to the FDA, let's say you had no response, it's possible that the body could have rejected the virus, could have rejected the gene. So the fact that it got in there and expressed and increased follistatin levels is the first indication that we had a biologic effect.
So we'll take one more question at this point.
Is there any interest in research on deceased bodies of patients with DM, and how would you go about volunteering for that? Not that I want to die tomorrow.
Yeah. Well,
Let's pass that down.
Yeah, currently we don't in our center.
I guess it stops right here. I'll be happy to. No, actually, I've had a couple questions like that in the past, but really, I can just say at the University of Pittsburgh, we're really not geared to be able to study subjects, deceased subjects like that. I don't know if anybody on the panel here is perhaps situated in a better way to do that.
So at Washington University in St. Louis, we actually have a set of procedures so that if someone with a particular neuromuscular disease is interested in donating their body or their brain or their muscles for research, usually you need to live in the area to do that. But if you live in the area of St. Louis, that's something that's possible to do.
So we'll temporarily hold the questions till the rest of the panel have their 2 minutes of fame. And thank Jerry and Zarifa. I believe you have to catch a plane, so thank you for your comments. And we'll start now. Dr. Levine has the microphone, so we'll let him start, and we'll just move down the table from
I'm Todd Levine. I'm a neuromuscular neurologist in Phoenix and really interested in all different forms of the inflammatory myopathies, PM, DM, and IBM. Over the last couple of years, my research has focused on trying to answer some very simple questions, which is, given medications that we have available, if you were to ask the panel up here how we use those medications, you would get 17 different answers because there really are not standardized ways, and therefore there's not a lot of standardized protocols. So I think last year I spoke to you about a study that I was beginning, which we've been doing now for the past year, looking at the use of IVIG in PM and DM. And trying to get an understanding of how physicians use IVIG and what kinds of effects that has on patients, both positive and negative. That study is still ongoing, but we're enrolling patients, and that's been going very well. This year, I sort of added on to that a drug you've heard a little bit about this meeting, a drug called Acthar, which is a drug which is approved for PM and DM, but one which does not have a lot of data, and it's not quite clear how physicians use that medication. And so again, I've created a registry to study patients that get the medications across the country and get a better understanding as to who's being prescribed the medication and how they might respond.
Good morning. My name is Chet Otis. I'm from the University of Pittsburgh. I'm a rheumatologist. I've been interested in myositis for probably 25 years now, and I've been a member of this board for a long time. I remember when the table was way smaller at the top of the stage here. But it's been, when you take care of a disease for as long as I have, you obviously becomes ingrained in your life. It becomes just part of you. And, the treatment and the assessment of patients with myositis has been, it's an overused term. It's a passion, obviously, but it really has become a part of me. And who we are up in on this table here on the stage is really myositis and the effect that it's had on our patients. So at Pitt, we've had the opportunity to conduct a large trial patients with polymyositis, actually adult PM, adult DM, and juvenile dermatomyositis. That study will be published fairly soon. It's been accepted for several months now, and it was a study that I actually presented the results last year in this meeting to the people that attended, the patients that attended. So it's the use of rituximab. Other people have used that medication for lots of other reasons, and the drug seemed to work, but the design of the study that we had was a bit flawed. And I don't want to say anything else about the study except that it has been published and it has been accepted and will be published very soon. So the other things that we do at Pitt is we're, of course, interested in seeing patients from all over, whether it's PM, DM, or IBM, and we're very interested in providing our opinion. We have a myositis center. There's a couple of us that work at that center, and we are in collaboration with neuromuscular pathologists and neurologists as well. So, again, I can answer any questions later on. I'll pass the microphone to Dr. Pestronk.
Before Alan makes his comments, Chet's being a little modest. I want you to all know that he and Ann Reed were the co-PIs for the RIM trial. They studied polymyositis in adults, dermatomyositis in adults, and JDM in a combined, I think it was 202 patients? 200 patients, which is almost twice as many patients that were ever studied in controlled trials. And the previous trials, there were like 7 of them, and none of them had more than 39 patients. The smallest was 15. They were able to put together an organization that studied 200 patients. So there's going to be a tremendous amount of new knowledge that came out of their efforts, and they should be congratulated.
Hi, my name is Alan Pestronk. I'm a professor of neurology and doctor of neuromuscular diseases at Washington University in St. Louis. Our interest is in a lot of different areas of muscle biology and immune myopathies. I have 3 specific interests. The first is that I'm a muscle pathologist, and I'm interested in new ways of looking at muscle and now probably skin pathology to help make more accurate diagnosis. It's my thesis that there are actually many different kinds of myositis, and that if you can identify which kind of myositis a particular patient has early on in their course, the doctor can then prescribe appropriate treatments without having to wait years or use medications that don't work for the particular kind of disease that you have. The second research that we're doing is that we're interested in dermatomyositis. It's our thesis that dermatomyositis is not one disease, that there are probably at least 2 or 3 different kinds of dermatomyositis which have different types of prognosis and probably respond to treatment in different ways. And for one of the types of dermatomyositis that occurs in children and some adults, we're doing research to try to understand what happens to the muscle fibers in those patients and what happens to the skin in those patients to make those patients weak and to get a rash. And then have the other complications such as calcinosis. And then the third area of research that we're interested in is inclusion body myositis. Some of you may have participated in our spit collection a couple of years ago to collect DNA, and we're using that DNA now to try to understand genetic factors that may predispose to inclusion body myositis. And to a second area that we're studying is the peculiar pathology of inclusion body myositis, where muscles sort of end up acting like accumulating a garbage can and accumulate all kinds of different molecules, and it's not clear why that happens. And a number of people in our group are studying what actually goes wrong with the muscle fibers and inclusion body myositis that might end up producing the weakness. And if we could figure that out, maybe we could figure out what an appropriate treatment is. So those are the main areas of research. I'd also say that, like Dr. Otis and almost everybody on the panel today, we have a large neuromuscular clinic that cares and treats for many patients with dermatomyositis, polymyositis, and inclusion body myositis. And our goal is to find ways of providing the best care for those patients as well.
Morning, I'm Tehsin Muzaffar. I'm a neurologist, a neuromuscular neurologist, currently at University of California, Irvine, where I run a large clinic taking care of patients with myositis of all sorts. I trained with Dr. Pestrong, and about 17 years ago, when I was a fellow with him, we got interested in looking at different pathology patterns in myositis, especially the antibody-associated myositis. And that's been an area of interest for mine, where I'm particularly interested in the predictive value of these antibodies, and especially the role that it plays. We want to look at the different levels and antibody titers and see how it predicts disease and whether it can be suppressed and treated. That's my role. We participate in a lot of clinical trials for that and collaborate a lot.
Next is Dr. Nagaraju, who is the chairman of the Medical Advisory Board at this time.
Thank you. I'm one of the odd ones here. My name is Nagaraju. I'm at the Children's National Medical Center in Washington, D.C. So unlike many, I'm a basic researcher. I'm an immunologist interested in studying myositis. So my mentor, Dr. Paul Plotz, introduced me to this disease in 1995. Since then, I continue to study what causes muscle weakness in myositis. That's the question I wanted to understand. And many of you know that the concept is that a lot of immune cells are there in the muscle. Probably they are damaging and causing weakness. So now, based on our studies in collaboration with Bob Wortman and others, we now found new mechanisms that are independent of lymphocyte-mediated damage that probably are responsible for muscle weakness in myositis. So now we're looking at how to modulate these pathways, mostly studying the mouse models of myositis, and try to find drugs and therapeutic interventions that alleviate the weakness in myositis. So I'm a basic researcher, but study both in the mouse models as well as in the human muscle tissues.
Good morning. I'm Lisa Christopher Stein. I'm a rheumatologist, and I work at Johns Hopkins at the Myositis Center along with Dr. Andy Mammon, who you'll hear from in a moment. I wear many hats, arguably too many of them at times. I became interested, like Raju, when Dr. Paul Plotz from the NIH really showed me the way. I have to say that it's always like a homecoming, coming back here. And I think that there were many mentors in my life, and many of them were you. The patient first taught me the interest in the disease, and then the scientist showed me the science behind it. I've been doing this for 10 years. And some of the highlighted projects that I'm involved in now or are becoming involved, one is an initiative with an acronym called STAMP. It is an international project across rheumatology and neurology to look at standardizing treatment options. As it was mentioned earlier in the panel, we all treat very differently, so we are trying to standardize truly a consensus approach to figure out what we do, why we do it, and how we should do it. The second big umbrella that I've become interested in is patient-reported outcomes, which sound pretty obvious, but interestingly, with most of the trials, short of a Likert scale, which is from 1 to 10 or 1 to 100, how do you feel? We have truly never asked the patient intensively how they do, what's important to them, and if the trial does well, is it really an outcome that's important and clinically meaningful? There is an organization or a large body of work in something called OMERACT, which originally stood for Outcome Measures in RA, clinical trials, rheumatoid arthritis. That umbrella has grown among many of the rheumatologic specialties, including vasculitis, spondyloarthritis, and related diseases, and now they've reached into myositis, so I'm helping to head that effort along with some other panel members here, including Ingrid Lundberg in Sweden. So stay tuned more for that. That organization is of interest to me because patients participate in all of the research. There is a patient who is a co-author on a study we are writing now. So I think it's very important. A very sort of different avenue also that I am now becoming interested in and collaborating with is cardiac outcomes, specifically interested in the myocardium. How does cardiac muscle differ from skeletal muscle? How is it important, and how are those outcomes important? And also the conduction system in the heart. Many people with dermatomyositis, I've noticed empirically, having treated many of them, have fast heart rates and other issues with the conduction system in the heart. So we are looking at that fairly intensively and hoping to match that against a large population control to see exactly what that means and is it clinically meaningful. And then finally, I'm always interested in unmet needs in clinical trials. And like Todd Levine and others, I'm very interested in novel therapies, especially for things like inclusion body myositis and in an up-and-coming player, immune-mediated necrotizing myopathy, which I think is something we're all understanding more. Finally, and from a quasi-science level, I am very, very interested on a personal level about how rheumatologists and neurologists can get along, talk about the disease, and further science. I think the piece I'm most proud of that I've ever written is not a major study or a clinical trial, but it's an editorial called Neurologists Are from Mars, Rheumatologists Are from Venus. And I stole the title. Admittedly, it's not clever, but it really highlighted to me in practicing in a multi-specialty clinic how much I didn't know, how differently we speak, and how important it is that we all get along and make this disease better. That's it.
Hello, my name is Christina Charles Showman. I am just so pleased to be here today. This is my first meeting. I'm an assistant clinical professor in the Division of Rheumatology at UCLA. I have been at UCLA for 16 years. I started specializing in myositis just a few years ago. I did that for two reasons. The first reason was that I found treatment of this patient population to be the most rewarding. The second reason is rheumatology at UCLA is really considered to be at the forefront of research in several areas, lupus being one of them, scleroderma being another. But absolutely no one at UCLA was studying myositis, and we have a lot of patients with myositis. So I'm happy to say at this point we have a cohort of over 100 patients with myositis, which is growing rapidly. One of the areas of research that I'm very interested in has to do with HDL, which is carrier of the so-called good cholesterol, and which normally protects the vasculature and is anti-inflammatory. And we are starting to see that HDL is abnormal in patients with dermatomyositis and may actually be pro-inflammatory with other abnormal characteristics. This is relevant because dermatomyositis is a disease which affects the vasculature. And there are therapies in development, and I'm thrilled to work with some people who have been at the forefront of this that improve the function of HDL and can make it protective to the vasculature. This has been very interesting work, and certainly we are always interested in additional therapies for something like dermatomyositis that are not immunosuppressant. We've got a lot of work to do, but this is what I've been up to. Thank you.
Hi, I'm Stephen Greenberg. I'm a neurologist at Harvard Medical School. I completed my training in my residency and fellowship at University of California, San Francisco in 1993, and then went into practice for 6 or 7 years, seeing patients full-time in California at Kaiser Permanente in San Francisco. During that period of time, I became very interested in myositis and frustrated by particularly IBM, but by other patients with IBM and my ability to not do sufficiently well by them. So I ended up leaving California and going to Boston, back to where I'd gone to medical school, and completing additional training to learn how to use a new technology, which was part of the genomic revolution at that time. And over the last 10 years have applied that technology to study of inflammatory myopathies, to inclusion body myositis in particular, but also to dermatomyositis. So currently I'm very interested in trying to find a treatment for IBM and better treatments for dermatomyositis. I've been involved in a number of drug development projects from very basic stages, developing rationale in my laboratory for those, as well as participating in clinical trials.
My name is Dana Asherman. I'm a rheumatologist, and I'm currently at the University of Miami, so not too far away. It's easy to get to this meeting this year. I would say that I can still remember my first patient with myositis when I was still a resident in internal medicine. And for whatever reason, that's fueled a more than 20-year interest now in this group of diseases, and it really underlies the research that I'm currently doing, which is twofold. I'm interested in the underlying immunologic mechanisms that contribute to disease. So in addition to seeing people, I'm a mouse doctor too. But the other part of the research that I'm involved in is more translational and reflects my interest in the relationship between the muscle and lung disease that many patients with myositis have. Currently looking for accessible, what we call biomarkers from the blood that help us identify characteristics of patients with myositis who might develop lung disease or have lung disease. And the hope is that basically that if we can identify these complications early on, that they'll be more amenable to treatment. So as many of you know, although the focus of our diseases is the muscle, in many subsets of patients with myositis, there are other equally problematic issues that we're trying to address.
Hello, my name is Bob Cooper. I'm a professor of rheumatology in Manchester, University of Manchester, and I've been doing myositis research for the last 14 years. Over the last 7 to 10 years, my life as a rheumatologist has been totally transformed because, for instance, in rheumatoid arthritis, there's fantastic new drugs, such as the biological agents like TNF-alpha. And one of the reasons why that was such a fantastic development, and Tiny Maney got a knighthood in the UK, was because he found a very, very important mechanism which made rheumatoid arthritis disease occur. And so for the first time, the drug companies with him were able to develop targets, specific targets. And the result now is that treatment for rheumatoid arthritis is fantastic. I mean, these drugs are totally life-changing for patients with rheumatoid, psoriatic arthritis, and ankylosing spondylitis. So if you then take that approach in myositis, the problem we have, of course, is that we don't know what the disease mechanisms are. So because I was working in Manchester, there's a very, very good genetic setup there. So 14 years ago, I started to work with genetics. But myositis is a rare disease, so most UK rheumatologists will see 6 or 7 or 8 cases in a whole career. So how to do research? Well, sitting at this top table, we can see how you do it in the States. You have dedicated even myositis centres. There's no such thing as a myositis centre in the UK. I run the biggest clinic, which is about 170 patients. But through activities like mine and from publications, colleagues in the UK are beginning now to set up at least dedicated myositis clinics. It'll be another 15, 20 years before we have myositis centres, I suppose. So my research is a correlation of myositis genes with myositis antibodies, because they are very, very closely correlated, and it will, I think, give us mechanistic clues in many of the disease subsets. And in order to do this work, it's grindingly difficult, and you need thousands of cases, for instance, to do genome-wide scans. And so through activities with people on this committee, I've been able to do collaborative work across Europe and across North America, and I'd like to thank Bob Goldberg and his colleagues for inviting me onto the committee, which has made such collaborations much more simple and possible. Thank you.
Thank you. I'm Steve Yetterberg. I'm a rheumatologist at Mayo Clinic in Rochester. And I got involved with myositis research, I hate to say 30 years ago, now as I start counting, when I was in training. And I was working in a virology lab in my training, and there was some interest in developing a model, and we looked at a model where we could cause what looked like myositis in mice. I've been blessed with the opportunity to see a lot of patients with myositis since I moved to Mayo about 14 years ago. I'm a clinical rheumatologist, and my time is spent mostly seeing patients, but I've had the opportunity to work with collaborators in the laboratory. Somebody mentioned Ann Reed earlier. Ann's a pediatric rheumatologist at Mayo who has a laboratory, and so we collect specimens that she analyzes, and we're looking at various immune mechanisms in myositis, as well as looking at clinical research studies with the patients that we see. Thank you.
My name is Adam Huber. I'm a pediatric rheumatologist at the IWK Health Center in Halifax, up in Canada, as well as a professor of pediatrics at Dalhousie University. I'm primarily a clinician, so my work is all clinical, and research that we're involved in currently is looking primarily at trying to refine how we assess children who have things like dermatomyositis. Recognizing these are complex illnesses, and sometimes it's very hard to figure out whether patients are weaker or stronger or improving or not improving. And more recently, we've been doing some additional work looking at predictors of outcome, specifically what influences whether children actually die with this disease, and then moving on to things like calcinosis and other such things.
Hello, my name is Yuri Vencovsky, and I'm a rheumatologist, and I work in the Institute of Rheumatology in Prague, Czech Republic. And I've been interested in myositis for almost 20 years. We have a database of patients in our institution, about 350, and we are trying to look at the autoantibodies and association of the autoantibodies with clinical features and prognostic significance. And soon we realized that we need many more patients to do so. And so I've been involved in the recent years in setting up the collaboration, large collaboration in Europe between different centers and between different countries. So what we did in the last few years, we established a network which is called EU MyoNet, European Myositis Network, which is supported by European Science Foundation. And one of the achievements that we achieved is that we formed a web-based registry for patients with myositis, where the data on patients are entered from different countries. So we now have more than 1,600 patients already in the registry, and we can do the research on the larger scale, including the genetic research that Bob mentioned. So because for these types of research, it's absolutely crucial to have large numbers. And I'm also interested in treatment, of course. So we now run 2 investigators-initiated trials. One has been ongoing for a long time. This is the trial where we want to know whether it's beneficial, whether it's good to add methotrexate to glucocorticoid to prednisone from the very beginning, from the onset of the disease, or whether it's sufficient to treat with prednisone alone and add some immunosuppression if it is not effective. So the trial, the recruitment will finish this year, so then probably 12 or 14 months since the end of this year we will know the results. And the second trial that is also investigators initiated, ongoing in 3 centers in Europe together with Ingrid Lundberg and investigators in London. We look at the compound that targets T cells that may have a very profound effect in in the pathogenesis of myositis. And in the lab, we collaborate with our group in our institutions. They are interested in fat tissue and proteins that are made by fat cells that have a very significant effect on immune cells. So we are looking at the possibility that some of these proteins from the fat tissue may have some role in myositis as well, but it's just ongoing research. Thank you.
Hi, my name's Andy Mammon. I'm a neurologist at Johns Hopkins, and about 5 years ago or 6 years ago, Lisa and I decided as a rheumatologist and neurologist to put together a multidisciplinary clinic along with our colleague Sonia Danoff from pulmonary medicine. So the three of us started off seeing patients kind of all together in one spot on a single day, and I think as Lisa was saying, we've learned a ton from each other. We've also seen a lot of patients and collected a lot of people into our cohort that Lisa really set up even before I started. And we've seen a lot of patients, and we've been able, I think, to make some discoveries because of the large number of patients. One of the things that Lisa and I worked on collaboratively together was identifying patients who seem to have autoimmune muscle disease that's triggered by statin use, and we've identified together a particular autoantibody that's only found in those patients and not patients who have other types of statin intolerance. And so we've been continuing to work on that. One of the things that we found that's interesting is that there's a genetic predisposition to developing that disease. And so we're quite interested in that disease because it's a case where we know both the genetic risk factors for the disease and an environmental trigger, and we're very interested in how those two things interact together to cause disease. I'm also interested in better understanding mechanisms of muscle injury in various forms of myositis, and working on understanding more about the immune response against muscle and skin tissue in dermatomyositis. So that's kind of what we're up to.
Thank you, everyone, for sharing your comments. And we'd like to open the floor for questions to any particular individual or about any particular topic. And if you hold your hand up so someone can take a microphone.
I've only seen a neurologist. Is there a reason to go to a rheumatologist, or just am I okay with a neurologist?
Of course. I don't know what baby said.
Why don't you take that one, Chet?
Well, look, a lot of it does depend on the manifestations of the disease and and first two things: what you feel comfortable with in terms of what you're being told, as well as what your physician feels comfortable with. For example, if a neurologist is treating a patient with inclusion body myositis, and there is little systemic involvement, then the neurologist is perfectly acceptable in managing that patient as perhaps as a rheumatologist. But if a patient has multi-system disease, for example, we see a ton of patients with interstitial lung disease. A neurologist may not be particularly tuned in to treating interstitial lung disease in a patient with multi-system disease compared to a rheumatologist, or they may not have the collaborative efforts available to them with a pulmonary specialist. So that's a tough question to really answer, and certainly we're not offending each other up here, but that's just my opinion right off the top.
I have two questions, one for Dr. Levine and one for Dr. Charles Shaman. For Dr. Levine, can you give a little bit more detail about how you're going about collecting the data for IVIG? Like, how are you getting it from other centers or physicians?
So it's a national effort that's being run through one particular home infusion company.
Can I ask which one?
Sure, it's called New Factor. And the concept basically is that by getting information about the patients prior to their treatment, by following the side effects and the dosing that the doctors give, because doctors dose it very differently, and then by using specific outcome measures that will be assessed to try to get a sense of how patients respond to the IVIG.
Are you open to accepting other companies such as Excelicare, which is what I use, and they're exclusively an IVIG company?
From a legal standpoint and a regulatory standpoint, it had to be simply one infusion company.
Okay, and then for Dr. Charles Shaman, I wanted to ask you if you could give a little bit more detail about the HDL abnormalities. I realize it might be over the head of a few people here, but I'd just be curious how you found out it was a pro-inflammatory marker as opposed to protective.
Yeah. Does this work? No. Okay, we're on. Hello? Hello. Okay, great. You know, this work actually started in other autoimmune diseases. It started in lupus and rheumatoid arthritis. And the work that we did in rheumatoid arthritis, what we started seeing is that when patients had a lot of inflammation, their disease was very active, the HDL was not protective. And to get in a little bit more detail for you, HDL actually is made up of a complex with multiple different proteins, which have capacity in its anti-inflammatory function. And they're very important, several of them, in preventing damage from something called oxidized phospholipids to the endothelium and the lining in the blood vessels. And so we started seeing in other patients, and particularly in the work that I've done in rheumatoid arthritis, that the very highly inflammatory patients, the HDL wasn't protective. And this work started in atherosclerosis 15, 20 years ago, when patients were coming into the cardiologist's office with very high levels of HDL cholesterol, and they had just had their bypass. And so they started looking at these patients and started seeing that the HDL actually wasn't protecting the blood vessels the way it should. When I started seeing patients with myositis and started learning more about the disease, it certainly had relevance to dermatomyositis in particular. These patients can be very inflammatory, and their vasculature is certainly affected in the muscle. And so that kind of triggered that we should look at this, and we're doing various tests at the moment to look at the proteome, the different proteins associated with the HDL, as well as the function of some of these proteins and the protein as a whole, with the thought being, if this does play a role, and there's a lot more work to be done to look at the muscle itself, which we're in process of looking at, but if it would be some way we could, you know, protect the vasculature in a different way, it could be useful. So I hope that helps.
I would like to raise a question with Dr. Cooper from Manchester and the Johns Hopkins people. I have read that there are genetic disposition on the part of people of Scottish background, particularly, to developing myopathy from statin-induced problems. Do any of you have information on the possible markers, genetic markers in Scottish people that have caused this problem?
The answer to that question is no. I mean, the results from Hopkins in respect to DR11, which is the genetic factor overall for Caucasians, I mean, that's hot off the press even this year. So no one's had the chance to look at that in Scottish cohorts.
The only thing I would add to that is that in addition to autoimmune muscle disease that can be caused by statins, there is what appears to be a sort of a self-limited statin intolerance that may be more common. And there's a specific genetic risk factor that's known to predispose people to having that form of statin intolerance. And I don't know about whether people from Scotland have that at a higher frequency than the rest of us, but it's probably about 1 to 2% of people who have that who are more susceptible, and it's probably going to be the case in the not terribly distant future that testing would be available beforehand to determine which people are going to be particularly vulnerable to that form of statin intolerance. Because at high doses of statins, about 15% of people who have 2 copies of that one gene are likely to develop muscle problems. So that's another sort of genetic predisposition to statin intolerance.
Hi, along with the first question that was asked, one of the things I struggle with is I understand dermer and polymyositis being together, but I guess the issue of IBM being included with the myositis, I know also it shares things in common with muscular dystrophy. So I want to understand that better.
Alan, you want to take that?
So is this on? Yeah. I think that the general answer to your question is that each of those diseases seems to produce muscle damage in a somewhat different way. Some of the mechanisms that produce muscle damage are immune, especially in dermatomyositis, and some other forms of polymyositis or immune and inflammatory myopathies. When we can identify what the autoimmune causes are, then they end up being treatable with disease, with medicines that can suppress immune mechanisms. With regard to inclusion body myositis, we have no idea what the underlying cause of the muscle fiber damage is, and so it's not hereditary in most cases, and so basically it's a mystery that everyone around on this platform has said we'd like to solve at some point. The difference between that and muscular dystrophies is that muscular dystrophies we know what causes most of them. There's a mutation in a gene that causes the mechanisms of the muscle fibers to not work, and you end up getting damage to the muscle fibers. So that in general then, inclusion body myositis fits into a general definition of, we use a word that says we're completely ignorant about what's going on in the nervous system. It's called neurodegeneration, and that means we have no idea what causes it, but we know what the disease is. The muscular dystrophies are caused by disorders in specific genes that cause the muscle problem instead.
I'm a first-time attendee, and a lot of this is foreign to me. You're speaking a different language. But is there a benefit to a gene study within my family or within myself? To my knowledge, I've not had any study of antibodies or genes.
Bob, you want to take that one?
One of the things that's been most remarkable in the last 3 to 5 years is just this fantastic correlation between antibodies and the HLA genes. If I know what your genotype was at HLA, I'd pretty likely be able to tell you what sort of myositis you were going to get if I knew you were going to get it in 12 months' time. I mean, the correlation is that good. So, and we know that serotype, your antibodies, predicts outcome. But I mean, it's not as accurate as that. I mean, some of the patients of mine who have done actually the very, very best have been JO1 positive, and yet JO1 it carries after cancer-associated myositis, the worst prognosis. So on an individual basis, the genes are predictive of phenotype, but not to the state where you could accurately predict for each individual outcomes to that level. But I mean, if you haven't had your genes done, then there are physicians like Fred Miller in North America who'd be desperate to have plasma and DNA from you to continue working our studies.
I believe I read several years ago that a species of python can be infected with IBM, and I was curious if anyone knows about that, if there's been any collaboration between veterinarian scientists and people studying human IBM?
Well, we have a veterinarian on the panel, so.
That's for the moderator.
You know anything about pythons? You're not a pythons vet? I don't know of any. I'm not familiar with that. Has anybody on the panel heard of the python?
I don't know anything about vipers, but dogs certainly get dermatomyositis.
Models and worms too.
Is it?
Yeah.
This is for Dr. Asherman. I got a question. Have you come across any kind of atrophy in the diaphragm of some of your IBM patients?
So the short answer is no. It's not something that I've encountered frequently. But I think there are many other people on this panel probably who focus more exclusively on IBM than I do, who may be able to better address that question.
So we routinely follow lung function tests in our patients that come through the clinic, and there are a subset of IBM patients who do show evidence for diaphragmatic dysfunction, and it's probably related to muscle factors, but it's not a usual course. But there are patients who are quite severe who do develop some evidence for diaphragmatic dysfunction.
Dr. Greenberg, I understood you to say that you are working on a cure for IBM and that you're also working on improvements on DM. I did not hear you mention PM, so I was wondering what the common link or common factor was between IBM and DM.
Sure. IBM and DM are very different diseases, but they're much more homogeneous diseases than PM. PM is a large group of different diseases. IBM may be different diseases, but it's certainly a smaller group, as is certain forms of DM. So they've been easier for me to study. I think I certainly would love to be working on treatments for PM, and perhaps some of the things that I've been studying in the other diseases might be applicable. But I've had a very hard time focusing on PM specifically because it's so many different diseases.
I recently read in one of our newspapers about methods to heal wounded troops. And this particular study was supposedly at the University of Pittsburgh, and it was by Dr. Badlack, and the study was regenerating muscle tissue, regrowing muscle tissue. Does Dr. Otis have any feedback on that for me?
I'm sorry, on regenerated muscle tissue, and the investigator was
there's a study
who?
being done, bioengineering of muscles.
Dr.
It was talking
Eward?
about excellular matrix. It was using pig material from this A Cell Incorporated from Columbia, and they were trying to regenerate, rebuild muscle tissue.
Actually, I don't know, maybe Dr. Ashman, he was at Pittsburgh as well, can answer. He may have known more of the basic science, but I know that there is a Center for Regenerative Medicine there. I know they are working on muscle satellite cells and other aspects of muscle regeneration, but I don't think that they have applied it actively to any type of patient with myopathy, to my understanding at this point. And that includes, there's a concept of sarcopenia, where there's just loss of muscle tissue over time. Sometimes it is just age-related. But as far as I understand, that group that is interested in this study, even in stem cells, has not looked at any other true myopathies in terms of any intervention, if that's what you were asking.
Yeah, this was basically for the wounded troops that came back from Afghanistan and the other areas recently. So there's a study on methods to heal wounded troops in various centers across the United States. But this particular one about regenerating the muscles was at the University of Pittsburgh.
I'm sorry, I can't expound on that further.
So we have a miracle of modern technology. Dr. Pestron can now answer the Python question. So by the miracle of modern technology, Dr. Pestron can now answer the Python question.
So the inclusion body disease in pythons has nothing to do with muscle. It's a nervous system disease, and is irrelevant to the myositis association.
One of the panel members mentioned a study being conducted over in Sweden. I would like to know what that study is about and where it was taking place at.
Well, the study is with the drug called abatacept. This is the drug that is used in patients with rheumatoid arthritis, approved drug for rheumatoid arthritis, because it's the drug that targets T cells that often infiltrate muscles in patients with myositis. We thought it would make a rationale to use it in patients with myositis. So the drug is now being tried in these patients.
Are there any studies being done on anti-Jo1 or ILD?
Well, I can repeat the question. The question was what studies are being done, and I guess in anti-Jo1 positive ILD patients. There would be a long answer to that question. There are a lot of, for example, companies that are interested in that disease, which you really can't expound on right now, but there are individuals, centers that are very interested in interstitial lung disease. We've had a long-standing interest in ILD for many years, and we've been participating in some smaller studies using different types of medications that some might not think would help in ILD. But I guess I can confidently say that because of that being the most prevalent autoantibody, and being more and more recognized, and also being more and more protein that is diverse in its manifestations, be it lung or muscle or skin or even arthritis, that there are really, there's a lot of interest in research on patients with Jo1. The whole trick would be to do it in a collaborative fashion and do it in a more unified fashion. And in the RIM study, for example, we had 25, 30 patients with the Jo1 antibody, and we'll be, I can't really go into it now because it's under control, but that will be presented in a couple of months. So I think you will see more and more. It's a challenging group of patients.
And so we do have, it is not yet approved, but I've been given funding for a small study specifically in the anti-synthetase syndrome, which would include Jo1, and not to advertise, and it's very small. It's a small observational study using a drug that's already approved in rheumatoid arthritis. But if any of you are interested, you can either email me or speak with me. We're looking probably between 5 to 7 patients. The status of that study is that it requires an IND, which is an indication for new drug. Those of you who saw Jerry Mendel present the IND with the ream of, I think he measured it actually by how high it was rather than how long. Certainly for a gene study, it's a bit different. But I will tell you, it is the most challenging thing from my standpoint to get through the IND process. So I believe the funding is there, the study design is there, the protocol is in, and the IND is pending. So my guess, I hope to say that by next year we would be not only enrolling but have some early data. So if anybody is specifically interested, you would have not had allowed to see rituximab in the last 1 year before the trial. So as long as you haven't been treated with rituximab within 1 year, you would be eligible to at least be screened in for the anti-synthetase trial. It's, again, small trial, observational only, and hopefully will then go to further testing.
I have a question. My sister has DM, then 5 years later, I was diagnosed with PM. Is that common in sisters, brothers, or family?
So I always worry when I see familial myositis, and usually it's concordant, so two people having the same disease. The most worrisome thing is PM. In my small experience. That's not common, although Fred Miller at the NIH would be very, very interested in talking to you and your sister. He's interested in specifically this question. He's interested in discordant siblings, so those that one is healthy and one is not. Specifically, it's called the twin sib study, twin sibling study, and he's spoken about that before. So I would say that it would require a careful review. There are described, I think this panel can speak about this, there are described family studies. I will say I don't know if any PMDM that I can remember, but there are familial myositis studies. The other autoimmune diseases, such as lupus and rheumatoid arthritis, clearly have a familial distribution, a familial predisposition. Scleroderma, once thought not to be, I think is now, again, I'm no scleroderma expert, but my understanding is that is a rare disease that's thought to be a little bit more familial than it once previously was, just probably owing to the rarity of the disease. We didn't see it. But I will say that I find it a little unnerving, a little uncomfortable when I hear of a familial story, and I always look for an alternative explanation first. Not impossible, but rare. That's what I would say.
So we have time for one more question before we break for lunch. So,
among some of the PM and DM patients who are here, they talk in terms of being in remission, something that makes me feel pretty jealous. Is there your kind of a definition that you all would accept as, yes, this is a patient in remission? How often do you see it? I hear it in terms of PM and DM, but not IBM, but I'm just curious, is it really something that we could hope for?
Todd, you want to take that?
It's a very good question. I think the first point is that because we don't have treatments for IBM, we don't talk about patients with IBM being in remission. We think of IBM as being a progressive disease. The goal for all of our patients with PM and DM is to achieve remission. I think that's what all of us up on the panel would hope to achieve, and so that's our goal for all of the patients. Our success rate is probably not as high as we'd like it to be, and I think the question comes into, are you in remission with treatment, meaning that basically you get back to normal strength, but you still require some types of immunosuppressive therapy. That I think we can achieve in a large percentage of patients. And then there's the possibility of remission/cure, meaning that the patient can get back to relatively normal strength without needing therapy. But that should be our goal for treating all the patients. I think we would mostly agree with that.
So I want to thank the panel for their answers to the questions and their contributions to the field. I know many of you are here for your first time, and you're also meeting people with the same disease as you for the first time, and I know that makes you feel very alone, but meeting people should help. When you were feeling more alone, you probably said, what's going on? Is there anybody doing anything about this, trying to learn more, find new treatments? And I certainly hear a lot of excitement by a lot of different individuals attacking this disease, and with the help and part of TMA, we'll make some more progress. And I also will volunteer each of the members for, you can tackle any of us with individual questions if you can catch us.
I want to thank the entire panel, including Bob Wortman, for sitting in and helping MC this. But even more importantly, I said at the beginning how dedicated and serious they are about this disease, and that they're truly the experts in this field. And I think you, after hearing them, can appreciate what I was referring to. They're a wonderful group of individuals. They work very hard for the Myositis Association and in turn for you. So with that, we are going to have luncheon here. You don't need to go anywhere except to be where the catering staff needs to put plates down. And so you may want to step out of the room if you want for a few minutes, but lunch is right here and hopefully the next 10 to 15 minutes.